Okay, so we're pretty clear on what's happened so far, right? Up to 2013, more people are getting coverage. We are spending more money on primary care. The government's clamping down a little bit now on what we have to be responsible for, not doing readmissions, making sure people reconcile their medications, maybe going for EMR incentives, try these other programs with accountable care organizations to save money. But now, how are we going to pay for this, and what are we really going to do? And that's where we're going to come to in a second for 2014. Val? I'm likely to not have all of the accurate details for you, and they do change pretty frequently, but one of the incarnations, and someone else in this room might be more expert at this than me, one of the rules as they're being written, and that's the way these bills work. A lot of things are spelled out in the legislation, but a great deal more is spelled out through committee work afterwards in small groups that get appointed by the Department of Health and Human Services. So it's basically for a month you can't be readmitted for certainly for the same problems. But there has been a great fight between doctors and the government, and I think it's a smart fight, because imagine, however, if it was anything, and this has to be resolved. For instance, you have someone who has heart failure. A 70-year-old gentleman's got heart failure. It's pretty common to have a little heart failure. They go into the hospital. But they also then drop they're cleaning up their garage, and they drop, a tire iron on their foot and have a laceration and end up having to have a surgical procedure. There's no reason to penalize a hospital for someone who's foolish enough to drop a tire iron on their foot in surgery, but who happened to have been in the hospital 2 or 3 weeks before for heart failure. And so initially it was for anything. I have been told that they're trying to reconcile that. I wish I could give you more specifics. And I will say this, go to the Health and Human Services website. They do update it pretty well, and I would say I found that their descriptions of their rules are pretty readable and they're pretty accessible. And they actually do take input, surprisingly. If you happen to go to a conference or they ask for input, it's not just hospital executives and leaders of physician organizations doing it, like at the AMA or the Family Practice Association. It's really anybody. And there also tends to be a pretty big uproar when a rule is really, really draconian, like it would be if it was for any health issue.
Yeah, there's a lot of cases.
Exactly. So, yeah. So I guess I should say again what Val was saying was, and she's a COPD advocate, of course. You could have COPD and heart disease and depression and diabetes, and so if you have one problem, they're admitted for your COPD. Should you be held accountable if they also don't take care of the other problems? But there are going to be restrictions. Let's be honest. We know that the expectation is going to be if you go into the hospital and you're spending time there and you're seeing a physician staff and a nursing staff, they want us to do a more holistic approach to the patient. They want us to make sure people are on the right medications, that they are not neglecting other problems, so that they do just come back 3 days later for, even if it's something different, but with something preventable. The spirit of the law is that they don't want people getting readmitted, period, in short periods of time because they need to shrink down that cost. Okay, so on healthcare.gov, it was just mentioned that you can do a search of the rules and regulations. And I'll be honest, I'm not great with details on some of these things because I tend to wait and let them see how they're going to breathe before they bring the rules in. I've been burned too many times where they give one rule and then it changes quickly and it changes again. I think it's better to give input until the implementation dates come. And usually common sense will prevail on some level for some of these rules. But that's why people are very afraid, because these are big changes to the healthcare system. Okay, so now we've talked about reimbursements, the readmission reform, and all the other things. So what happens in 2014? 2014, the mandate lands, okay? And the individual mandate is really the cornerstone of this bill. The idea, again, is that you need to capture everybody. You can't just have people who are generally healthy don't want to pay for insurance outside of the system because you end up skewing the system towards just the more expensive individuals and health insurance becomes too unaffordable. That's the premise. So the individual mandate is basically a requirement that everyone in our country is insured. And here's how it works. If you have insurance, you are able to keep your insurance. But meanwhile, states across the country, and it will be almost all states, and if the state doesn't do it, the federal government will apply it to your state, will apply an exchange. And you've seen a lot of that action here because Hawaii, being a pretty blue state, frankly, we were quick to decide to pass a bill to create the health insurance exchange. So the health insurance exchange is really meant to be like a portal where anybody can go and compare plans that have at least a standard that is good enough. They picked HMSA's PPO standard, I believe, and that way that's what you get. And you can bid across the different choices, and that's a place where you can't, no one will be able to vulture down on you and take advantage if you're just you have a family business of 4 people or 6 people, and somebody had a pre-existing condition that took care of that. That was one big problem, or somebody else was elderly and they treated them unfairly, or someone was a woman, and that was the ultimate discrimination, where women were being discriminated against and having much higher premiums. Why? Because in childbearing years, at least this was probably the reason. Yes? The comment was being discriminated against over 60. And so all of those, there's a major attempt to close those discriminatory policies down and to have the health insurance exchanges available and really practical for people to use. So those go into play, and 80% of the people on health insurance exchanges will, they believe, be subsidized in some way, because the health insurance exchange will, of course, be not for people really who are on Medicaid. Medicaid programs will still exist, but for people anywhere in the poverty zone, from 100% of federal poverty up to 400%, if they aren't qualifying for a Medicaid program in their state, which the feds are going to be providing extra resources for, they'll get a tax credit, so it won't be a demand that you pay it even though you're still pretty poor as a family of 4 or 6 and have no chance, because there are penalties associated with it. I think that they'll probably visit this again in the legislatures. I would not be surprised at all, because it was a tough, even for me, it was a tough pill to swallow to imagine people being fined if they refused to buy something. It's a kind of a fundamental question, which a lot of Americans are going to tend to have a hemorrhoid over, right? Which will be covered though under Obamacare. So, the penalties are like $95 for an individual adult, or up to 1% of their salary, whichever is greater, in the first year. I drew a little chart for myself. For 2015, $315 per adult, or 2% of their earnings, and then it goes up to $695 per adult, or 5% of their earnings, whichever is greater. So, just to give you an example, let's say you're outside of that gap, which is up to $88,000 for a family of 4. That's the threshold, the highest threshold of 400% of federal poverty. So let's say you made $100,000 for the math to be easy for the family, and you just did not want to go for health insurance, which is going to cost you. We can discuss what that would cost you, right? But if you refused to pay into the system and it was $100,000, you would pay a $1,000 penalty that first year. And presumably, that money for the family would then go toward additional purchasing pools, or humanitarian care clinics, or just compensating hospitals for the care they delivered for someone who showed up and was uninsured. You might still get bills. Actually, not clear in my mind exactly what would happen, but it goes up and up. Let's say you're a family that makes $200,000 and you just insist on not participating in a national health program. By the third year, you would pay, 2.5% of that $200,000, which would be a $5,000 penalty. And that would still be significantly, as you know, less than what it's going to cost for that family of 4 in a healthcare program. So are questions that still remain. Healthcare costs are still going up everywhere. They're going up less in Hawaii anyway, but some places they've been trying to get ahead of this curve and charge us a little bit more. So you can see that that's going to be a very big kind of change in philosophy. And at the same time that we're putting together the health insurance exchanges and having people basically apply the individual mandate, I want to say be punished with an individual mandate, because it is meant to get everyone together on health care, we're also going to be expanding Medicaid, so that there are many individuals still across the country that just couldn't qualify for Medicaid because states didn't have enough resource. The federal government is generous in the first few years until these systems are put into place. But I'll be honest, this is the stuff that gives John McCain fits, right? Because he's conservative and he really didn't like the idea of expansion of social programs. Just him. I'm not being critical. I'm just saying that's what the conservative spectrum were worried about, or a man. And people on the liberal side of the spectrum, or Barack Obama, they were saying, no, this is a social program that is smart, that is worth doing, and we'll try to keep it some balance. Definite major philosophical conflict. There's no question. So I'm going to talk just for a couple more minutes, and then I can really open up to questions, because I wanted to mention a couple of the things that are kind of the wild cards in my mind about the Healthcare Affordable Care Act. One is what will happen to physicians. So if we do go to a system, because this money has to come from somewhere, and a lot of the savings, so to speak, coming out of Medicare. And in order to do that, those of you who run programs that rely on Medicare reimbursements, or hospitals that have had Medicare populations utilize them, which is a lot of facilities, right? Almost everyone, because the people we see are people over 65. For the most part, it's not just that little kid who put the weed up, the shredded weed up. Because I also last night had a kid, a grandpa who had chest pains, and he was on Medicare, and he had to treat as though he might have a heart attack. Thank God he did. But, those are the people we care for in our facilities. If the reimbursements don't cover costs adequately, we can run into the scenario that we suffered at HMC West, which was gradually adrift to insolvency and losing services. So we're going to have to be very mindful that make sure the reimbursements actually are adequate for our professional workforce. There's no way around it. It has to be addressed, should be addressed directly and sensibly, and you get what you pay for. If you don't pay for those services, you can get very good services from other providers, nurse practitioners and what have you, but they're not the same services, and so people have to be familiar with what they're getting and accept it. That's one thing. Two, we're already, today, we have 950,000 physicians in the country. So that number is 4 years old. But so about 950,000 to 1 million physicians. But the shortage is profound in a lot of places, especially rural areas. We in Hawaii, David and Kelly Withy worked hard on this project. We have about a 22% shortage was our initial report. It's kind of flatlined, doing some good things with the loan payment program and getting medical school to focus on primary care people, have people stay. But we're still short, and the population continues to become older and has more needs. So we, at a time where we're shrinking the amount of money potentially into healthcare, we have to find a way to get more people to provide healthcare. And that's a fundamental problem. And I don't know that there's a good solution built into the Affordable Care Act yet. That's probably my largest concern.